My sincere greetings from Baltimore, USA. I'm very grateful to, I'm very grateful to the organizers of Bangladesh International Medical Students Scientific Congress organizers for giving me this opportunity to talk about my topic, which is reproductive age women and COVID milieu. Let me introduce myself. I'm Dr. Halida Hanum Akhter. I'm a Bangladeshi. Currently, I'm a faculty at the International Health Department of Johns Hopkins Bloomberg School of Public Health. I'm here since last 2.5 years, but before that, I was in Bangladesh. I'm basically a reproductive health epidemiologist. I did my MBBS from Dhaka Medical College long time ago, and then I did my MCPS, and then I did my master's in public health and doctorate in public health from Johns Hopkins University. And I spent 2 years at Centers for Disease Control in Atlanta, going through their training process, which is Epidemic Intelligence Services as a Rockefeller Fellow. In my presentation, I have one page that I will share with you my public health journey, and I will give you more details about my basic interest is reproductive health, women's reproductive health, and all relevant issues. And throughout my career, I have involved myself into this topic. I have founded a reproductive health research institute in Bangladesh and conducted research, conducted a lot of research methodology courses, and given training to many people, and use these research findings for advocacy to the senior government people, to the general people, to the NGOs. So I have been doing advocacy on reproductive health issues and how to improve reproductive health of women. And I think today's lecture will also reflect giving you information about what do we mean by reproductive health. What are the components of reproductive health? What are the issues of the reproductive health? Not only Bangladesh issue, but also the Southeast Asia regional issue, some global issue, and how today COVID is affecting women's life. So I'll be talking about that. And I would like to thank again the organizers of this esteemed conference. I'm so pleased to be part of you. So as I mentioned, my today's topic is women's reproductive age and COVID-19 milieu. I have put in a lot of data in my slides. I'm not going to read all of them, but the reason is that since this will stay on and you can look at them more in details later and will be useful to use them for your research, for your literature review and everything. So what I would like to share with you is the diagram of life cycle approach to reproductive health illness, reproductive illness. And this has been developed by World Health Organization a long time ago after ICPD. ICPD is International Conference on Population and Development that happened in Cairo in 1994, which endorsed commitment to women's life, realize their rights, national level laws, policies, and entitlements for all across their life cycle. And I call this a boat. What you look at, this is a boat, but this is a life cycle level of illness that women go through throughout their life. Starting from adolescence to elderly, you can see the list of conditions, list of ill health or illnesses that are there. I'm quickly reading it, but we will be talking some of these later in my presentation. So in many countries, there are female genital mutilation at early adolescence. In poor countries, malnutrition, anemia. In rich countries, obesity, these are the major problem. Unwanted pregnancy is a problem. Reproductive tract infection, sexually transmitted diseases, infertility, HIV, AIDS, gender-based violence, sexual violence, unregulated fertility, and maternal mortality and morbidity. In addition to that, cancers, and in a postmenopausal phase, the osteoporosis, prolapse, and also elderly, they have their own issues. So when I look at reproductive health, this life cycle illness come in front of me, and I think those who are responsible, those who are working, this picture should come in front of them. Very quickly, I'm going to review the definition of reproductive health. This definition was finalized before Cairo conference in the United Nations Preparatory Committee in New York, and I was the co-chair, I was the vice chair of this chapter 7 of Program of Action, and my responsibility was because of the global country leaders were there, the government people were there. They all had to say yes to every word in this sentence. And my responsibility was to negotiate with them, get their vetting, get their approval for each and every word. So I'm reading this one because you will not find them in many places. So when I look at reproductive health, the reproductive health is a state of complete physical, mental, and social well-being, and not merely the absence of diseases or infirmity in all matters relating to the reproductive system and to its functions and processes. This is like regular health definition, but the subsequent 2 paragraphs are very special. It talks about satisfaction, it talks about freedom to decide, it talks about choice, it talks about rights and rights to access and decision-making power. So I'm going to read that second paragraph is that reproductive health therefore implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. So the reproduction becomes a freedom to decide, not imposed. Implicit in this last condition are the right of men and women to be informed and to have access to safe, effective, affordable, and acceptable method of family planning of their choice, as well as other methods of their choice for regulation of fertility, which are not against the law, and the right of access to appropriate healthcare services that will enable women to go safely through pregnancy and childbirth and provide couples with the best chance of having a healthy infant. It's a long definition, but it has all the components of well-being, of reproductive well-being. If you look at this one, the elements that came out from this definition is family planning, safe motherhood, safe abortion facilities, infant care and child care, male participation, responsible behavior, adolescent reproductive health, infertility, reproductive RTI, STD, HIV/AIDS, cancer. That what we have seen, these are all part of the service elements and the interventions. And ICPT documented that women are facing threats in their whole life just because they are overburdened with work and they have no lack of power to make decisions for their own well-being, for their own life. So since all the governments were part of the Cairo conference, they were co-signatory of this definition of reproductive health. And they co-signed that when they come back to their own country, they will incorporate reproductive health in their health program, in their family planning program. And I was part of that very much, and help government to articulate, to give training and all these things. And government developed an essential service package of reproductive and child health. And these are all the services that are part of the ESP, or essential service package for the reproductive health and child health. If you go to the government document, you will see all of those things in the operational plan, and I will share with you some of those during my presentation. There are some cross-cutting issues like behavior change, communication, communicable disease, also addressing the diseases that come as a non-communicable diseases, NCDs. This queue I did because none of these are separate items. They are all interconnected, and it comes as a package. Otherwise, we will not be able to address these problems. My next section will be adolescent reproductive health. This is a critical time in women's life. And I'm talking about a little bit about South Asia region because they are our neighbors, and we may have a lot of participants who come from those countries, and they will find themselves here. Globally, 1.2 billion adolescents are there today. Out of that, 350 million live in Southeast Asia region, and they constitute about 15 to 26% of the total population. And if you look at this graph, you will see that these are age-specific fertility rate. And if you look at the taller columns are Bangladesh, Nepal, and India. In these places, the adolescents have higher age-specific fertility. And if you look at these multiple colors, they are 15 years, 16 years, 17 years, 18 years, 19 years, and you will see that these are the fertility rates that are showing. So what we see that, adolescents, because they are crossroad between childhood and adulthood, they face many challenges, uncertainties in their lives. They have limited access to information. They have limited power to make decisions for their own lives. And these are more prevalent in countries like India, Nepal, Bangladesh, where early marriage is there. And we see that in many countries, adolescent pregnancy in these regions are within marriage, but also in many countries, and also in these countries, there are many pregnancies outside marriage, and those are also something to be considered as a part of the package. Let us talk a little bit more about the adolescent pregnancy. Why adolescent pregnancy is a problem. It's a challenge. It's a challenge and threat to the life of the adolescent. Globally, if you in Southeast Asia region, estimated 6 million adolescents are giving birth each year within their adolescence time, before within 15 to 19. So why it is a problem? Because adolescent pregnancy is associated with higher maternal mortality, higher maternal morbidities, and adverse child outcome. So there is a high prevalence of low birth weight among adolescent pregnancy. When you go to the gynae obstetrics studies, you will see that there are high risk pregnancies. And all adolescent pregnancies are high risk pregnancy. There is a higher perinatal, higher neonatal, higher infant mortality, as well as compared to the older women. Low access to modern contraceptive to the sexually active adolescents. So these are major problems. Also, we see a high unmet need for family planning. They need family planning, but they do not have access. They have unintended pregnancies. And when we look at the survey data, adolescents, they have 17% unmet need, whereas the national data is 12% unmet need. They need family planning services. And so when we look at the age, if you see that the mothers under age 18 are twice as likely to die from their pregnancy, and under age 15, pregnant women are 5 times more likely to die from the complications of pregnancy over the 18-year age group when we compare these two groups. So let us look at quickly the female adolescents in Bangladesh. We have 1/5 of our total population adolescents. Out of that, approximately half of them, which is 16 million, are female adolescents. They have many health problems, but one I would like to share with you, which is pertinent here, is 13% of these adolescents are short stature. They are short, less than 145 centimeter. And why short is a problem? Because they have a greater risk of mortality and complications during delivery. They may have obstructed labor because of the small pelvis. They may have other issues of accessing care and many other things. And also their babies that they will deliver also have low birth weight. So these are some of the issues related to adolescent pregnancy. In Bangladesh, 59% of the girls are married before 18 and 22% before 15. And 1/3 of these 60% girls of age 15 to 19 become pregnant. So you can see which is higher in rural as compared to the urban, which is a higher level of issue that we have to deal with. What also we see that an estimated 2 million births, 17% of the total births, are among adolescents 15 to 19 years. So this is a major issue and adolescent pregnancy is a major problem to the life. There is another aspect that I would like to draw your attention is the violence against adolescents. Today, in the newspaper in Bangladesh, you see rape, killing, many things that has been going on, and that there have been lot of rages going on against violence and punishing the violators and the perpetrators. And in BBS, Bangladesh Bureau of Statistics, they did a study in 2015, and they found that nearly 43% of married adolescents, they said that they have been physically and sexually abused in their lifetime. 28%, 28.5%, they say they are physically and sexually violated in last 1 year, in 12 months. There are non-partner violences that we have been seeing, and which is about 28% of the girls say that they have been violated both sexually and physically. Now, given these major issues related to adolescents, how can we help them? What kind of services they need? We call them youth-friendly services. What will be the nature of youth-friendly services? Youth-friendly services should be friendly. They should be welcoming. You know that we have provider problems. Providers do not welcome adolescents. Adolescents do not want to go to them because they will be rebuked. So it has to be friendly, respectful, judgmental, non-judgmental, and private. There should be confidentiality as well. Age-appropriate care, because 10 to 14 may have a different kind of issues, and 15 to 19 may have a different kind of issues, so it has to be age-appropriate. And definitely the consent, permission has to be taken from them. When we look at the key elements that need to frame the services, focusing young people, it are WHO approved, I'm sure. I see that the care, youth-friendly care, youth-friendly services should be accessible and affordable, should be acceptable to the adolescents, so that they can easily access. It should be equitable, not a select group, not only urban, but not rural or poor or rich. So it should be equitable. It should be very appropriate to their age. It should be effective. What we give them, that should change their life, that should do the purpose for which it was given. I wanted to show this one because this is a good advocacy tool for anybody. And in USAID, we call it high impact practices. And the name of this one is healthy timing and spacing of pregnancy. So there are 5 information, like no marriage before 18, no child before 20, no children after age 35, and minimum spacing between the 2 children should be 3 years, and minimum spacing after abortion should be 6 months, not before that. This is a nice picture that I always love. So this is minimum, bare minimum, that is adolescent sexual reproductive health services. These services should be available in any country, in any facility, in any premises where adolescents are there. Adolescents, as you know, that a large proportion of the country. And the book that you see, Nije Ke Jano, is a government developed and government approved Bangla, talking about their growing understanding to the adulthood from adolescence, during adolescence. But this is available. This is for the adolescent male and adolescent female, but this is not available to the extent that it should be available. It has good information. When I was the chief of party of the Smiling Sun project, we procured from the government. We took their soft copy and printed, but that was not enough. This should be available to all the schools, colleges, and also to the non-school going girls and boys in the country. Very quickly, when we provide adolescents services, we can also look at the segmental approach because they have a different kind of need. So unmarried adolescents, they have a different need. Newly married adolescents, they have a different need. Young and pregnant adolescents, they have like one child or first-time parent. So these are very, in that program, I named Angel Model. And so that the people go to the adolescents and provide services as in a segmental approach. However, we talked about adolescent, and we have programs that we are saying that yes, we have adolescent program, but when the globe reviews the global availability of services to the adolescents, in various UN sessions, you will see that they have made recommendations. What are the unfinished agenda after ICPD or after Millennium Development Goal that we were not able to achieve? One is the institutionalize the investment for young people to gain demographic dividend. We talk about demographic dividend a lot. We do not have yet an universal access to a package of youth-friendly health services, as I just described. However, government has to be accountable, more and more accountable, to address the harmful traditional practices. And what are the harmful traditional practices? These are early and forced marriage, genital mutilation in many countries, gender-based violence, and violence against women. These have to be reduced and disappeared from the globe. So these are, and quality services that are available in the quality services should be there, maternal health, maternal mortality, morbidity. These are still a long-term unfinished agenda. Whenever we talk, we see that we have more ways to go, and we have long list of things that we have not yet achieved. Our next, I would like to share with you the gender-based violence, because I think it's important to know. There are many things that we do not study in medical colleges. There are many things that we do not address in our normal clinical and medical guidance. This picture I love to show you, that a woman or a female goes through her life the various types of gender-based violence. This gender-based violence is also throughout the life cycle. You know that the pre-birth, when the baby fetus is in the female fetus is in the mother's uterus, she is sex selected, and the abortion happens. In many countries, in neighboring countries, there are practices when they find out through sonography that the child is female, they will abort. So there is a sex selection and abortion. Besides, there are a lot of violence, physical abuse to the pregnant women, and that affects birth outcome as well. In infancy, we know there are discriminatory behavior. There are also infanticide. There are neglect. There is a differential access to food and medical care for the girl infants. You look at boys and girls in a different eye. Girls are less privileged and boys are more privileged. Also, I mean, you will find a lot of research on these. You go and search and you will see a lot of research has been done globally and also in Bangladesh. Girlhood child, when we look at girlhood is another issue. There are child marriages, there are sexual abuse. You will see that lack of medical care, again, lack of services. If she has diarrhea, she will be taken when she's almost dying. But if a boy has diarrhea, after one sickness, you will take him immediately. So there are behavioral problems from the parents' side. Adolescence, we have talked about adolescent. All these things that we talked has been a major issue. We know that the coerced sex abuse, harassment, prostitution, trafficking of women, and these are all adolescent are the victims of those ones. And reproductive age, we'll be talking more about that. Reproductive age, women's violence, their mortality, their morbidity, and homicide and psychological abuse. There are many things that is happening, and the data is available. I mean, you are interested in data, you will go and find everything. This is a data from 2015. If you look at the gender-based violence in Bangladesh, the Bureau of Statistics, they did a study in 2011 and 15. If you look at the 15, if you look at the bottom line, 72.6, almost 73% women said that in their lifetime they have been violated, either physical, sexual, emotional, or economic. So out of 100 women, 73 women undergo gender-based violence, which has reduced a little bit. It was 80% in 2011 survey. Now it is 73, only a small reduction over a period of 4 to 5 years. But there are many other issues, like sexual violence is there. Pregnant women also become a victim of violence, and we have seen that about 28% go to hospital and get the treatment for their injury, so that the injury is so serious in nature. This is quickly, there's a lot of things, but what I would like to do, three messages that I would like to share with you. What are the barriers of gender-based violence? Is screening. You will see that there are many issues that women think they are afraid of raising voice because they do not go anywhere they suffer violence, but they do not go anywhere for their solution. They have fear of victimization. They are helpless, because they are so dependent on their spouse, parents, or in-laws. Where would they go? They are not earning member. They fear of losing their shelter, and also they have less reliance or less trust on the law, legal aspects of the country, or the uniform based activities. But there are both government and non-government organizations who can help them. There are also Ministry of Women and Children's Affairs. They have centers. They have Gender-Based Violence Victim Support Center. Also, there are police stations and local government institutions. There are NGOs like BLAST, BRAC, Mohila Porishad, Aino Shalish Kendro, Lighthouse Co. So these are the organizations who are working to help women in reducing gender-based violence, but it's very negligible. It's very, in the Smiling Sun we have tried, but they do not want to go for any litigation or anything. Let us now talk about maternal mortality. It's a major issue, and it's very close to my heart. Still, mothers are dying because of their pregnancy. And when I speak on maternal mortality, I do like to start with this quote from a mother. A mother is saying that I'm going to the sea to fetch a new baby. But the journey is long and dangerous, and I may not return. What a great statement. This is true. Every word of it is so true today. When you look at Hopkins, I'm working with maternal death stories. Like in a trial, there were women, when they do prospective data collection, women's death have been identified. They have taken the narratives, and when I look at them, you feel like crying. How, because of lack of care, because of lack of money, and because she's a woman, she cannot make her decision. She had to accept death, and it's so vivid. So what happens when a woman dies? Her children are more prone to death because of the lack of care. The woman herself is deprived, the family is deprived, the country loses a young person. Globally, what is happening? Globally, when we see that an estimated 300,000 women die annually due to maternal causes. This is a large number that one can accept. Now, the more concerning is that more than half of these world's deaths, they pass by undocumented. There is no documentation. We do not know how many women died and what are the causes of death. How she died. These information are absolutely needed because of the health planning of that particular country, because of prioritizing the interventions to reduce maternal mortality in that particular country. Without documentation, that country cannot plan. And this is a major concern today. And you will see that the statistics now, and this is very painful to see that we are missing vital event data. This is a vital event, like birth registration, death registration. This is absolutely important, and especially the maternal death, because of there is a need for reduction of maternal death. So when we look at these numbers, if you look at the 88 countries of the world lack complete data, because they have some data, but those are incomplete. 27 countries have no data at all. Only 65 countries have complete data. However, over 80% of all births are happening, or deaths, or even more deaths, are happening in those countries where there is no death data, either incomplete or do not exist. So you can imagine the situation of maternal conditions, maternal deaths. Very quickly, the definition of maternal death. That maternal death is a ratio. It's a ratio, maternal mortality ratio. And this death of women while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from the accidental or incidental. Whereas when we look at pregnancy-related death, that includes accidental and incidental, but within the same time frame, like while pregnant or within 42 days. But anything that coexists with pregnancy will be documented in the pregnancy-related death. So for the maternal death, you need a medical certification, good verbal autopsy, and good decision, scientific decision, expert decision to decide that yes, this is a maternal death. Others are not so much needed. Very quickly, little more information about the maternal mortality. When the maternal death occur, what is the highest? So if you look at during pregnancy, it is from 11 to 17% of all deaths that occur due to pregnancy. 50 to 71% occur during the postpartum period. And that is so important, that postpartum period, 50 to 71%, nearly 1/3 die and late. And where do they die? You know, the 99% in developing countries. So the maternal mortality is highest in developing country. 99% of the maternal deaths occur in the developing country. And this is a human development indicator. If I meet a person that I have never been and don't know much, if I ask that person, what is your maternal mortality ratio? That will tell me what is the development stage that country is currently now. So this is an important indicator, development indicator. And that a country, the more developed a country, the lower its maternal mortality ratio. So this is a measurement ratio. And maternal mortality ratio, the formula, as you know, that it is number of maternal death divided by number of live births in that country, in that particular area, in that particular year. So that is what is important. Very quickly, what are the direct and indirect causes of maternal deaths? When we look at industrialized country, developed country, it is 12 per 100,000 live birth. When we come to the South Asian countries, it is 176 per 100,000 live birth. Look at the number in South Asian countries. When we go to Sub-Saharan Africa, it is 546 per 100,000 live births. So there is so much diversity in the countries, and you can see that the more developed, it goes with the development of that country, development of the health system, development of the healthcare, and the overall development of that particular country. However, there is something to look forward to. There is something to be to be happy about, but not to be complacent about. One is that we have seen that between 1990 and 2015, in 25 years, there have been a 44% reduction of maternal mortality globally. In Bangladesh, there have been 40% reduction between 1 and 10. And when we look at the direct and indirect obstetric causes, I will show you the slides. So direct obstetric causes are hemorrhage, eclampsia, sepsis, obstetric labor, obstructed labor, and complications of abortion. And indirect obstetric causes are mostly the NCDs, non-communicable diseases. And as you know, that the NCD constitute about 80% of NCD deaths globally. And the reason I'm saying this one, because women of reproductive age are increasingly affected by non-communicable diseases, and majority of these are indirect causes of death during pregnancy. These two pie charts are two different things. One, the first one on the left side is all causes of death among women of 15 to 49 years. That is, during reproductive age, what are the causes of death that women die? And this has come from the Bangladesh Maternal Mortality Survey 2016 done in Bangladesh. And you can look at that the cancers and the circulatory diseases, they constitute 47% of all female deaths. There are others, but the red one on the left side, the maternal cause is 13% out of all deaths. So pregnancy-related death, women are dying at 13% rate. On the right side, that if we take that 13% and constitute 100%, the causes of death due to pregnancy are eclampsia and hemorrhage. 31% are hemorrhage and eclampsia is 24%. So 55% of the deaths, maternal related deaths, are because of eclampsia and hemorrhage. When people tell me, I said hemorrhage is the highest killer and eclampsia is the second highest killer of a woman who is pregnant. Indirect causes are also important because we see that in many countries, in our country also, the indirect causes of maternal death, and there have to be a program existing to reduce NCD because NCDs affect pregnancy. And what are the NCDs? Like metabolic condition, diabetes, hypo and hyperthyroidism, cardiovascular system, hypertension, rheumatic heart disease, chronic. If these are existing with pregnancy, these are exacerbated because of the pregnancy. Anemia, sickle cell anemia, thalassemia, cancer, neoplasm, kidney disease, and obesity. These are all pre-existing factors that affect the outcome of pregnancy. And in Bangladesh, we see that 15% of the maternal mortality ratio are due to NCD or pre-existing conditions. And when we look at globally, 1/3 of the maternal death are because of the indirect causes and not directly from the obstetrics. As I mentioned already that there have been 40% reduction. So in Bangladesh, the maternal mortality declined by 66% between 1990 to 2010, and 40% reduction has happened between 2001 and 10. So in 10 years, we have been able, in MDG, we were very close to our Millennium Development Goal. We almost missed it for a little bit, but we have achieved a lot. We have achieved quite a significant proportion. This is very quickly, I wanted to show you this one. These are the causes of maternal mortality. And when we look at 2010 and 2016, in some area, there have been reduction. In indirect, there have been reduction from 68 to 38. But if you look at during pregnancy, there was hemorrhage and eclampsia has increased. But also if you look at abortion, you will see that it was 2 and it became 15. These are the numbers. So out of 196 per 100,000 death maternal mortality ratio in Bangladesh, 15 women are dying per 100,000 due to their abortion complications. So this is important because all these are preventable, and abortion is preventable. As you know that in Bangladesh, menstrual regulation program is available. Both medical menstrual regulation as well as manual vacuum aspiration or surgical abortion MR is available. And why then 15 per 100,000 women have to die? And I think I wanted to show you this one. And the right side graph shows that, as mentioned earlier also, the highest proportion of death is during the postpartum period. And that is important for the practitioner, for the researcher, and for the programmer and the policy, everything. Since I was talking about abortion, I think it is important. You are not going to get this data from you can search and find out, but not in regular presentations and others. So when we look at the number of treated cases per 1,000 women aged 15 to 44, there is an abortion worldwide report. I have taken from there. And you will see that in the developing region, nearly 7 women per 1,000 aged 15 to 44, they have taken treatment for their serious abortion complication. In Africa, it is again 7 per 1,000 women 15 to 44. In Asia, it is 8. You can see that in Asia, it is higher. And Latin America, 5.3. As you know that the abortion complications related to the services available, related to the unrestricted service available, related to many stigma that is attached to that. And this has both pregnancy among married, pregnancy among unmarried, and social stigma, and all these things. In Bangladesh, as I just mentioned, that the 15 women die from complications of induced abortion per 100,000 live births, and this is the latest data from 2016 Bangladesh Maternal Mortality Survey. An estimated 1,194,000 induced abortions or MRs are performed in 2014 in Bangladesh, and 647,000 in 2010. The number reduction is a concern because the need has not reduced, but if the numbers of the procedures are not given, if the procedure is not given in by a medically trained provider, then complications are bound to rise. And what we have seen that nationwide, 257,000 women were treated for complications of induced abortion, reflecting a rate of 6 per 1,000 women aged 15 to 49. So this is a major issue in reproductive age women, let alone among adolescents or reproductive age women. Just to give you an understanding that in 2014, an estimated 2.8 million pregnancies in Bangladesh, that 48% of all pregnancies were unintended. The mothers did not want it. So when a pregnancy is unintended, they do not want to keep it. They will try their best to abort it or to discontinue it. And then the medically trained procedures, medically available procedures are not available to all of them. And they go to the clandestine and have complications. And that's a major issue. I would like to talk about family planning because sometimes we think family planning is a logistics, it's a condom, pill, and implant and all these things, injectables. No. The way I look at, after my MBBS, I joined family planning, which is very, very unique and unnatural at that time. But I have seen that family planning is a life-saving intervention. It is a life-saving resource for a woman because it reduces high-risk pregnancy. Once high-risk pregnancy is reduced, the maternal mortality will get reduced. And globally, we know that family planning is responsible for 35% reduction of maternal mortality. So that is so important, that family planning, I thought that I must talk about family planning. The impact of family planning, if you look at on the right side of the column, you will see that from the Guttmacher Institute in New York in 2012, they say that the use of modern contraceptives, including the provision of information, counseling, and services in a developing world, prevented so many events, like 218 million unintended pregnancies were prevented because of use of modern contraceptive. 55 million unplanned births were prevented. 138 million abortions were prevented. 118,000 maternal deaths were prevented. And 1.1 million infant deaths were prevented. So this family planning, use of modern contraceptive is a life-saving intervention, and I do advocacy on that whenever I get opportunity, because this information is not known to many people. So while we invest in sexual and reproductive health and save life, we have seen globally that 1 in 3 women experiencing complications during their pregnancy and delivery receive care. That means out of 3 women, 1 woman receives care for their complications during pregnancy and delivery, and also for their newborn need. If she does not care, then her baby does not get the care. And when in those areas, providing full contraceptive, maternal and newborn care is provided, then that would reduce the annual large number of maternal deaths, ranging from 300,000 to 84,000. Also will reduce newborn deaths from 2.7 million to 500,000 and over deaths. So these family planning and providing contraceptive and maternal and newborn care reduces mortalities, reduces deaths, reduces complications. Globally, 214 million women in developing region have an unmet need for modern contraceptive. Meeting this unmet need also reduces and results in 75% decline in unintended pregnancy, unplanned birth, and many other things. So what we have seen from those countries in Southeast Asia region who have made a progress in reducing their maternal mortality, three things I would like to end here. First is that the policymakers are aware that this is a major problem. Maternal mortality is a major problem. Second is they developed a strategy which constitute a whole spectrum of the care, not just antenatal care, but a full professional care that includes childbirth, backed up by hospital care or emergency obstetric care. And third one is have everybody access to care, both financial and geographical. So these are important things that for the policymakers, that if we want to improve in a country, our program should invest in these. Let us talk a little bit about the maternal mortality ratio target in Bangladesh. We know that we have completed in 2015 our MDG, but we have in front of us Sustainable Development Goal, SDG. So our government in the fourth Health Population Nutrition Sector Program, HPNSP, government has planned that by 2022, 21 is next door, next few months. So in 1 year from now, we are going to reduce our maternal mortality ratio from 196 to 105. That means we are going to reduce, that's in our book, in our plan, in our operational plan, that we will make it half. I hope we can do it, but I don't know how we will do it. But that's an aspiration in the government document, and everybody should work on that. In SDG, that's another 10 years later, what we see that we would like to bring it down to 70%, more than to 70 deaths per 1,000 live birth. So these two are aspirations, and government is committed to bring down, and I think the challenge is there a bit high. Very quickly, in our fourth Health and Nutrition Population Program, what we see that the priorities are given to family planning, antenatal care, institutional delivery, taking program to the hard-to-reach area, especially the community skilled birth attendants, EMOC facilities, improve quality of care. Also, there are few strategies like midwifery training program, operational plan, CSBA training program, and then emergency obstetric care and NCDs. I'm not going to read this one because of the time, but there are women's health issues that is related to environment. And you can see that the exposure to physical and chemical agents in the workplace, in the household, both indoor exposure, cooking and other things, there are entire life cycle is at risk, like infertility, hypofertility, spontaneous abortion. There may be congenital malformation, there may be cancers of the spring or genital and breast cancer due to exposure. So this is not something that we will forget because there are women's health issues. Also, when we look at the air pollution, we see that still in low and middle income countries, around 3 billion people still cook with solid fuel, wood, waste, charcoal, coal, cow dung, kerosene and other things. And these create constant pollution, air pollution. And these pollutions are affecting fertility and health during pregnancy. And we have to remember that. Again, this is kind of environmental something that we have to think very seriously. The slide shows that I took it from the World Bank. It's Sushmita Dasgupta, who is a lead environmental economist, mentioned that climate change is going to create severe poverty traps. Unless we address the climate change problem now, sustainable poverty reduction will remain a dream. Climate change is a major issue for all of us, but particularly for the poor and vulnerable. And who are the most vulnerable people? If you look at on the right side, you will see the poor, the children, the women, and are disadvantaged. And the female-headed poor household and the household that have no male earning member suffer the worst because they are the most disadvantaged, they are landless, they are marginal and all these things. Also, we should not forget the ready-made garments. They are majority, so women's sexual and reproductive health among the ready-made garments or the R&G industry. You know that the 4,700 garments factory They have employed 4 million workers, and the large majority, largest employer of women, and the large proportion of them are women workers. They are mostly migrants. They are disadvantaged. They are poor. They live in a very poor condition. They eat less because they live in a crowded place. So that, and I had an opportunity to review their availability of sexual and reproductive health among the garments factory, and I saw that, I went to review that they have less information, less services than they need, less knowledge about reproductive health, about family planning, and what type of care they should. So this is a large Bangladeshi group of women that needs a special attention for their reproductive health care. Very quickly, I would like to go through, because I'm a public health person and I cannot just skip this talking about public health. I know that you may have other people who will be, other speakers who will be talking about public health, but I will take you through. So what do we mean by public health? You know, the way we understand that public health is basically protecting the health of entire population. It's the entire neighborhood, it's the entire country, it's the entire region. When you go to hospital, we take care of a patient. A patient comes with disease and we treat that person, and he recovers, he goes back. But public health deals with that person does not have to go to hospital. You prevent the disease, you protect from having that disease. Having a promotion of healthy lifestyle, and understand the disease and various injury prevention. And these are very important aspects. And the public health covers a whole lot of things like science, mathematical science, social science, policy, economics. You talk about other things. But if you want to go to the more clinical aspect of it, there are preventive aspects of clinical. There are public health aspects of diabetes, heart disability, drug abuse, obesity. So it's a wide range of areas that a public health professional can cover and can get introduced to and can have a public health career. And there are many roles that one can play in public health career, and I enjoy learning about that, doing more about that. What they can do, they limit health disparities, you know, like poor, rich, adolescent, young, married, unmarried. There are major disparities. There are major difficulties in those, and promote healthcare equity. How can you make it equitable? Promote healthcare accessibility. You can monitor health. You foster safe and healthful environment, and then implement protection, because science is so much, because science, they incorporate science knowledge and improve the life of people. That's what is important. And you can provide leadership, you can provide training, you can provide services as well. And then prevent various problems. So there are many ways of mitigating these public health problems is through educational program, recommend policy, then you add intervention, administer services, and policy changes, strategy changes. There are many areas that a public health person, a public health expert can intervene and can enjoy the opportunity. And they can be scientists, they can be behavioralists, they can be manager, leader, coordinator, academicians, of course. And you can find a job when you have a public health expertise. You can find a job in government, local, state, federal, multinational organization, international NGOs. When I was in Bangladesh last 5 years, I was country representative of Pathfinder International, and have enjoyed working in my own home country. That was the best thing that I can ever ask for. But there are also private non-profit and private profit organizations. And if you look at the public health concentration like epidemiology, biostatistics, environmental health, health education, behavior, I mean, you can policy, nutrition, you can name anything, and this is expanding. This is an area that is expanding depending on the mother's need. So this I have talked, and I'm not going to read this one, but you can be many things in the public health career. And this slide is basically for those who are not doctors or nurses, but have a health science background, biological science background, psychology and other things, but not a doctor or a nurse. But they also have an extensive career opportunity in public health. And I would like to give them a hope that if they explore, they can do a whole lot of work in a medical setup, and they can contribute a lot. So there is a career opportunity for the people who have health sciences background. Now this page is crowded. That's me. That's me, because this is me and my public health journey. And I'm not going to read this. I leave this for you to read later, whoever is reviewing this program. But quickly I can say that I have worked with the government, Ministry of Family Planning, with the Family Planning Board. After I graduated from Dhaka Medical College, I joined Family Planning Board. I became a project director of Mohammadpur Fertility Services and Training Center, and I learned a lot about family planning, women's health, reproductive health, menstrual regulation, tubal ligation, went abroad. I was sent to many countries to learn more, to do research. And then I came to Hopkins to do my master's and doctorate in public health, and then went back and worked with Ford Foundation. And then I founded a reproductive health research institute named BARPART under the ministry as a quasi-government organization. After that, I was Director General Family Planning Association, and then many other jobs. So I had some international jobs, and you can look at those. Pathfinder, World Bank. I was in World Bank Washington also, and worked with several African countries, and that was a great opportunity for me to learn more and do more. I have been in WHO committees for a long time, for 16 years, in various committees related to reproductive health. And many international committees and organizations and evaluations, and also in the Cairo conference preparatory process, even PrepCom 2, even PrepCom 3. And as I mentioned, I was vice chair for the reproductive health chapter 7. I was with London IPPF as in their medical advisory panel. So I'm not going to say a whole lot of things. I think the final thing is that I was awarded for my contribution in this area, for my contribution to the women's health improvement by United Nations Population Department. So I received an UN Population Award in 2006 as an individual category. I also received various awards from German World Bank through the Justus Liebig University and many others. I've been on the board and on the chair of many international organizations, as well as many Bangladeshi organizations. So the reason I'm showing this one is not to brag about me, but to give an example that if you pursue your public health career, what opportunities you get globally as well as in your own country. So this is an inspirational slide that I would like to inspire people. And I have done throughout my life to inspire people to come to public health, to come to women's health, to come to reproductive health, to come to research, and go to academia. And go and do your higher studies, as many needed. So that is so important. And how your self-development efforts. I mean, I'm not going to read all of those things, but you can volunteer, you can mentor others, you can do more courses, you join professional organizations and contribute. Professional certification, whatever is available, do that. Now there are a lot of COVID-related contact tracing training is available free of cost. You go to the website, get the training, get the certificate. So you develop yourself, you create a learning program, you do more, you contribute, you be the mentor, you create a new mentor. So there are so many things that you can self-develop and continue to rise, continue to move on. I know that the time is gone. So let me talk about women and COVID-19. I know that this is important, but you will hear from many other speakers who are COVID experts. I'm not COVID expert, but I can see that how COVID has affected life of a woman. That's what. But there are certain advantages of women in relation to COVID-19 as compared to the male. What we have seen from various reviews and speaking and all these things, that the case fatality is higher in male and lower in female as compared to the male. When there was Middle East respiratory syndrome in 2014, that also had 62% male infection rate as compared to 38% female infection rate. Also case fatality was higher for male as compared to the female. That was very significant. So this is one advantage for women, that the fatality is lower than male for the COVID. What is the reason for this protection? One is that there is a stronger immune response among women than men. That has been said. Also, why besides that, the women's female sex hormone like estrogen and progesterone is protective. And also because women are caregivers, if they become a little bit sick, they seek care. Otherwise, the family will be suffering. So they take care quickly. They're conscious about the hand washing. They're conscious about their wearing mask and protecting their family members. However, we see that the health workers are majority female. So that gives them access to knowledge and also various amenities that they can protect themselves. As they are close to them. And another good thing is that women smoke less as compared to the male. And that's how their probably lungs is much better protected and less affected by COVID as compared to the male. So these are some of the advantages of female in relation to the COVID as compared to the male. However, there are disadvantages of women, and that has been globally recorded. And what we see that the women are disproportionately affected, both mentally, emotionally, and physically. There are many circumstances like they provide unpaid care, they are domestic workers, they lose job, and they have loss of income, and all these things affect and add to their mental and emotional health. Burden of caregiving, they have a household responsibility, they take care of their husband, other family members. If elderly is living with them, they take care of them. Children, they have to take care. In countries, although globally, there are school homeworks, their children are not going to school, so they have to take care of the children, the homework. If she is employed, then she has to carry out her own office work, sitting at home while taking other cares. Globally, what we have also seen that women make up 70% of the global health and social workforce. And therefore, women are on the front line of the COVID-19 response. There have been so much talk about the higher risk of the frontline COVID-19 workers, and they need very good protection and other things. We have seen that among women workers in Italy, USA, Germany, Spain, they range from 68 to 75%. So there are more women workers closer to the COVID patients, and they are at a much higher risk of exposure to the COVID patient. However, what we have seen, there is a Lancet article also, that the PPE, the protection equipment that they get, personal protection equipment that they get, the masks that they get, these are produced in a larger size, like even if it is a medium size or a large size fitting men, then that becomes difficulty for women. They need extra effort to put their belt, to have tight mask and face shield and other things. But the problem is not in tightening. The problem is that it does not give them full protection because it is loose. So they are less protective. They have higher risk of infection, although death is less among them, but the higher risk of infection and sufferings and all these things. So this is another disadvantage for women during the COVID period. If we look at the greater, aspect of women in terms of their reproductive health care availability, and what are the problems, you can very easily imagine. And we have been hearing webinar of many international projects in many developing countries. They have made some strides, but it's a major setback because family planning logistics is not available. Abortion services are not available. Antenatal care, delivery services, newborn care, postpartum care, these are not for pregnant women, to the delivering women. One is the scare of touching the patient, not knowing if she is infected or not. Non-availability of menstrual regulation if someone needs abortion care or the menstrual regulation care. So the availability of services have become a big concern for the people who need it. So the providers are also need to have protection. And I was reading an Indian study that they have done very recently, and they have seen a major 50, 40, 30% reduction in all these cares available to the people who need badly. Definitely these lockdown restrictions have disruptions, like supply chain disruptions and availability of care, availability of the worker, because many of the hospitals are giving care for COVID and the other people cannot go non-COVID. In Bangladesh, you have to have a test negative to get a hospital entry. If you are not tested, you have to have that test. Let us talk a little bit about the gender-based violence again. Very quickly, I will say that these are among the reproductive age women. And during COVID, we know that the violence already highly prevalent in the globe among the women. But this COVID-19 lockdown, staying at home, staying in large intergenerational population size family, the violence has increased. The control over the woman, that has increased. And the nature of violence is both physical, mental, economical, sexual. You think about that, that there is increase. When I was reviewing, I saw that during the first 2 weeks of quarantine, Colombia, the violence phone call increased by 130%. In Chile, 70%. In Kenya, 34%. In Bangladesh, I do not have a current data, so I cannot cite, but definitely gender-based violence has increased among pregnant women as well. So what are the consequences of violence? Anxiety, stress, depression leading to thinking of suicide, ideation of suicide. Women are more prone to suicide. There are homicides from fighting, from all these things. Women are more vulnerable to above all these consequences, as I mentioned that. And suicide, we have seen globally that suicide is more common among women of reproductive age globally. So these are major concerns on the women's life when we think of gender-based violence during COVID time. There are questions about risk of pregnancy in COVID-19 positive women. If a woman who is pregnant and positive with COVID-19, what are the risks? Basically, we do not have very good research on that, but CDC and other organizations and United Kingdom, they have reviewed the affected women and collected data. So these are individual study, woman study from where we know the data. And they have found that there is an increased susceptibility to viral respiratory infection among women who are pregnant. Because during pregnancy, the woman undergo immunologic and physiologic changes in her body, and that makes her more susceptible to viral respiratory infection. And also we see that the risk of complications are also with the poor outcome, and also if she has comorbidities, such as diabetes, hypertension, COPD, severe asthma, cystic fibrosis, sickle cell anemia, and other cardiovascular conditions. So these comorbidities also increases her risk of complications. So these case studies of CDC and UK obstetric statistics survey, they have seen that the infection risk in the pregnant women is same as non-pregnant women. So that's one good thing, except during the third trimester where premature labor and intrauterine deaths are reported in some conditions. Wherever what they have found that there are 5.4 times more likely to be hospitalized by a pregnant woman as compared to the non-pregnant. 1.5 times more likely to be admitted to ICU as compared to the non-pregnant women, and 1.7 times more likely to receive artificial ventilators if she is pregnant and woman. Risk of death, no difference in risk of death among between the pregnant and non-pregnant women. And however, we have seen that these case studies seen that the cesarean section rates seem to be higher by 60% in UK, and half were COVID related and may reflect comorbidities. So if a woman is COVID related, if she is pregnant, if she has comorbidities, definitely to save the baby and the mother, there may be indications for cesarean section to save lives. There are also questions of the vertical transmission in COVID-19 positive women. You know, when she is pregnant, whether there is a vertical transmission to the baby or not. The CDC case series study, they have found that no fetal effect so far. When they looked at amniotic fluid, they found that amniotic fluid of COVID-19 positive mother is negative. They looked at placenta also negative for the virus among the COVID-19 positive pregnant women. 2.5% babies tested positive. 5.6% babies tested positive with the mother positive. So when 2%, 5% babies are tested positive, they think that it could be a nosocomial infection because she is pregnant and she is admitted to COVID-19 ward and other things. So there may be infection coming from others. However, they also found that there is no increase in neonatal ICUs or need. So these are good things about the vertical transmission and the good for the baby, even if mother is COVID positive. Breastfeeding is one of the another major concern, and when they examined breast milk, they found it negative for virus, even if the mother is positive. If mother is COVID positive, mother can breastfeed the baby. There is a CDC guidance on that. She can breastfeed directly. She can clean her breast, wear mask. She can have face shield and feed the baby by herself. But if she is sick or otherwise, then her milk could be expressed, sterilized, and given to the baby by somebody else. I'm not going to talk a little more about contact tracing. Maybe other people will be talking, but this is the time that contact tracing is important for Bangladesh. I know that in US, this has been a major issue. Some wanted, some did not want, but there have been a strong CDC guidance that contact tracing has to be done to prevent, to protect, to mitigate further spread of COVID-19. So what they do, you identify the exposed to COVID-19, you monitor health, signs and symptoms, get tested, and then self-isolate who they find exposed, and then self-quarantine among the close contact and all these things. So these are, someone can read more carefully and understand, but there have been success stories that in several countries like South Korea, New Zealand, they have aggressively used contact tracing. Wuhan, China, they have aggressively, with 9,000 contact tracers, and they have been continuing contact tracing and has mitigated their COVID-19 cases. If we look at Ebola virus experience, SARS outbreak and other things, and even sexually transmitted infection and other, contact tracing has been done aggressively to stop this spread of these conditions. I have just given this slide that these are the medicines that is available now for the treatment of COVID-19. I'm not going to talk much about it, but we know about remdesivir. This is a broad spectrum antiviral used in Ebola. Chloroquine, it has been a major debate on that, and the FDA, they have withdrawn, they have revoked their authorization, which they gave for a short time. There are other, dexamethasone, we know that it has been given, it is in practice, and there are other medicines in the frontier. However, it is very important to give symptomatic treatment and also protection and prevention in 3W, washing hand, wear mask, watch distance. These are very important. About the vaccine status, I know that this is so important, and this is, everybody is waiting for that. Globally, what we have seen that more than 165 vaccine candidates are in research, are in the human trial. Some are in human trial, some are pre-human trial. If you look at the bottom one, like 135 in preclinical, not yet human trial, 21 phase 1, 13 phase 2, 8 phase 3, 2 approved for early and limited EM. And in many countries like Taiwan, Cuba, Russia, they have been working very diligently to have a vaccine available. And especially in US, they are thinking that first quarter of next year, we will have vaccines available for mass use. This we do not have to read, but this is someone can read later that what are the phases of vaccine trial. There is a preclinical, there is phase 1 safety trial, phase 2 expanded trial, phase 3 efficacy trial, and then approval, and then available for the mass population. So these are the phases that a trial has to go through. There have been 5 recommendations for a gendered lens for COVID-19, and these must be used, and these have been recommended by various groups, is that you ensure that the policies around COVID-19 are exclusive of everyone's need. So everyone should get the advantage. Also prevent diversion of resources. Sometimes the resources that for the women care or the sexual reproductive health care are diverted to another program, but that should not be done. Incorporate voices of women, in the frontline response. Prioritize the collection of accurate and disaggregated, sex disaggregated data so that we know what is to be done, and the research effort should be continuing. Johns Hopkins is doing a lot of research, have been the spokes organization in all those things that is going on in TV program and everything. You will see that they are pioneers in COVID research and all these things. And there should be safety net for women and sexual reproductive health care. Quickly, I would like to go to unfinished reproductive health agenda in ICPD. We talked about that, but still we have youth-friendly services are not yet available. Government has to address these gender-based violence, maternal health, maternal mortality, morbidity, universal access to reproductive health, quality, and government has to commit to realize the rights of women and the women's health and their entitlement throughout their life cycle approach, and access to family planning services, and reduce recourse to abortion. We have to reduce recourse to abortion because that creates. Globally, women have been thinking, and everybody have been thinking, that whether we should have women's agency. We do have many women's, in Bangladesh, Nari Pokho, there are many organizations who are women agency. They're talking about women. I'm one of the women agency in person that talking about, advocating about women's disadvantages, women's distress, women's conditions and all these things, and that we should bring to the notice of the policymaker, of the strategy, of the investors and all these things. So this is very important to think about women's agency and whether it is a solution or not. Again, a large unfinished agenda. Again, this one I will read quickly, that still early marriage is imposed on children, on women, although there have been global condemnation on the human rights basis. When we say victim of violence, survivor, we call them survivor. But a woman who is victim of early marriage cannot survive. We cannot call her survivor because she may have fistula and she may suffer throughout her life. So we have to think of all these things and understand the constraints of her life, the sufferings of her life. And these are still unfinished and we see all over. So this is my last slide. And my appeal to everyone that given the maternal health, mortality, morbidity, and they are all linked with poverty. They are all linked with disadvantages, condition of women, and all this unfinished agenda we need to achieve for a healthier women. We have to give attention. We have to give resources. We have to give commitment and accountability for a healthier woman. And my personal theme is always listen to women.